This is the story of the most prescribed diabetes drug on the planet and why up to half of the people who start taking it quit within the first year. Roughly 150 million people take metformin every day around the world. Across the United States in 2023, doctors wrote more than 85 million prescriptions for it, which made metformin the second most prescribed medication in the country, trailing only the cholesterol drug atorvastatin. A month's supply costs as little as $4. Every major medical organization on Earth recommends it as their top treatment for type 2 diabetes. And yet, somewhere between 36 and 54% of patients walk away from it inside of 12 months. That gap between what doctors recommend and what patients actually do tells us something went wrong, and today we are going to figure out what. We are covering every major reason people stop taking metformin, all backed by published research, and we are separating the real concerns from the fears that have no business driving your decisions. If you have ever thought about quitting this medication on your own, you need to hear this first. What metformin actually does. Before we get into why people stop, let us make sure you understand what this drug does once it enters your body. Metformin belongs to a drug class called biguanides, and its primary job is turning down glucose production in your liver. Picture your liver as a sugar factory running 24 hours a day. When you have type 2 diabetes, that factory overproduces and metformin slows it down. On top of that, it decreases the amount of sugar your intestines absorb from food and helps your muscles respond to insulin more efficiently. Two things metformin does not do set it apart from most other diabetes drugs. Weight gain is not one of its side effects, and many people actually drop a modest amount of weight while on it. Low blood sugar is also not a concern when metformin is used alone because it does not push your pancreas into making extra insulin. Those two qualities together are unusual in this category of medications. The FDA approved metformin for type 2 diabetes, but doctors also prescribe it off-label for polycystic ovary syndrome, prediabetes, and antipsychotic-induced weight gain. When it comes to preventing diabetes in people with prediabetes, the American Diabetes Association currently recommends metformin as the only medication for that purpose. And here is a piece of the story most people never hear. Metformin traces its roots to a plant called Galega officinalis, better known as French lilac. Medieval European herbalists used this flowering plant to treat the intense thirst and frequent urination we now recognize as diabetes symptoms. Scientists eventually identified a compound in the plant called guanidine, which lowers blood sugar, and a refined version of that compound was first synthesized in 1922 by two Dublin chemists named Emil Werner and James Bell. But the person who brought metformin into actual clinical use for diabetes was a French physician named Jean Stern, who published his results in 1957 and gave the drug its famous brand name, glucophage, which translates from French as glucose eater. What makes that timeline surprising is that metformin was already being used across Europe by the late 1950s, and the FDA did not approve it in the United States until 1995. That is a gap of almost 40 years. The reason for that delay comes down to fear, and that same fear is still pushing people to quit the drug today. The numbers. How many people actually quit? The research on metformin discontinuation paints a consistent and troubling picture. A large study using United Kingdom medical records, published in 2020, followed over 11,000 new metformin users, and within 12 months, 35.9% of them had stopped. Among patients who had already been on the drug for some time, 23.1% still quit inside of a year. The numbers from the United States are even worse. A study of nearly 24,000 patients with prediabetes found that 54% abandoned metformin within the first year, and by year 2, that figure climbed to nearly 70%. Researchers at Weill Cornell Medical College tried to understand the reasons behind this. About 30% of patients who stopped cited side effects, which makes sense. But here is where things get strange. Nearly 9% never filled the prescription at all. About 7% decided they no longer needed the drug because lifestyle changes like diet and exercise had improved their condition. And in more than 50% of cases, no reason for stopping appeared anywhere in the medical record, which meant these patients simply vanished from treatment and nobody documented why. Despite these numbers, metformin still holds the highest adherence and persistence rates of any diabetes drug class. The issue is not that metformin performs worse than the alternatives. Taking any daily medication for a chronic condition is difficult enough on its own, and metformin carries some specific side effects that tip people toward giving up. Reason number 1, the stomach problems. Gastrointestinal side effects are the #1 documented reason people stop taking metformin, and this is where most of the damage happens. A 2022 meta-analysis pulling data from 71 clinical trials reported that about 13% of metformin users develop diarrhea, around 9% deal with bloating, roughly 6.5% experience abdominal pain, a similar percentage report nausea, and about 4% suffer from vomiting. Broader estimates put the overall GI side effect rate between 20 and 30%, and one clinical review noted that up to 75% of patients experience at least some gastrointestinal symptom, even if mild and temporary. But here's the detail that could save your relationship with this drug. Two forms of metformin exist, immediate release and extended release, and the difference between them is dramatic. Clinical studies showed that 53% of people on the immediate release version reported diarrhea, compared to just 10% on extended release. Nausea dropped from 26% down to 7% with the switch, and less than 1% of people on the extended release form needed to stop because of side effects. That difference held up in practice too. A study of 471 patients found that moving from immediate release to extended release cut GI problems from 26.3% down to 11.7%, which is a meaningful drop from a simple medication swap. Most of these stomach issues show up during the first few weeks and clear up within about 2 weeks for the majority of patients. Standard advice from doctors is to start at 500 milligrams per day, increase gradually, and always take the pill with food. When problems stick around, switching to the extended release form usually handles it. One thing to watch for if you have been on metformin for years, though. Chronic diarrhea can develop long after you have been stable on the drug, and when it does, doctors sometimes misdiagnose it as irritable bowel syndrome or diabetic diarrhea. If unexplained digestive problems appear after years of metformin use, bring it up with your doctor, because adjusting the dose or switching to extended release might be all it takes. Dr. James Flory, an endocrinologist at Memorial Sloan Kettering who has studied metformin adherence extensively, put it this way, quote, "I tell them to let me know if they are having side effects and we will work on it. Do not just stop taking the drug and never circle back," end quote. That advice alone could keep thousands of patients on a medication that is working for them. Reason number 2, vitamin B12 deficiency. Most patients hear nothing about this risk until symptoms have already started, and that is the problem. The longest randomized study examining metformin and vitamin B12 came from the Diabetes Prevention Program Outcomes Study, led by Dr. Vanita Arota. 5 years in, B12 deficiency showed up in 4.3% of metformin users compared to 2.3% on placebo. When borderline low levels were included, those numbers jumped to 19.1% versus 9.5%. Each additional year on the drug increased the risk of deficiency by 13%. Separately, the FDA prescribing label for glucophage notes that subnormal B12 levels appeared in approximately 7% of patients during clinical trials. For seniors, that matters a great deal. Vitamin B12 deficiency triggers peripheral neuropathy, meaning numbness and tingling in the hands and feet, along with cognitive effects like memory problems and confusion. And it also causes anemia. And this is where it gets tricky. Those symptoms overlap almost perfectly with diabetic neuropathy, which means a patient could be told their tingling feet come from diabetes, when the actual culprit, or at least a major contributor, is a B12 deficiency caused by their own medication. The American Diabetes Association now recommends annual B12 testing for anyone who has taken metformin longer than 4 years. Their most specific guidance on this topic yet. If you are on metformin and nobody has checked your B12 levels recently, that is a conversation to have at your next appointment. Reason number 3, the fear of lactic acidosis. Fear and reality pull in opposite directions on this one, and the gap between them is enormous. Lactic acidosis is a dangerous buildup of lactic acid in the blood, and patients and even some healthcare providers worry about it with metformin. That worry is the main reason the United States held off on approving this drug for nearly 4 decades. But the fear traces back to a case of mistaken identity. An older drug called fenformin deserves the blame. Fenformin belongs to the same drug family as metformin, and it was yanked from the US market in 1977. After causing lactic acidosis at rates of 40 to 64 cases per 100,000 patient years. That was a real crisis. Metformin's rate sits at roughly 3 to 10 cases per 100,000 patient years, about 10 times lower. The strongest piece of evidence on this comes from a Cochrane meta-analysis. covering 347 clinical trials and over 70,000 patient years of metformin use. 0 cases of lactic acidosis turned up in either the metformin group or the comparison groups, not one. A 2018 study of over 132,000 patients went further and found that metformin users actually experienced acidosis at a lower rate than patients on no diabetes medication at all. Dr. Robert Misbin captured the situation perfectly in a 2004 article published in Diabetes Care. The title alone tells the story: The Phantom of Lactic Acidosis Due to Metformin in Patients with Diabetes. His argument was that the risk amounted to a ghost, haunting metformin because of the sins of its predecessor drug. None of this means lactic acidosis cannot happen. It can, but almost exclusively in patients with severe kidney disease, liver disease, sepsis, serious dehydration, or shock, conditions where the drug builds up because the kidneys cannot clear it fast enough. For patients with normal or mildly reduced kidney function, the actual risk is close to non-existent. Reason number 4, kidney concerns in older adults. Because metformin leaves your body entirely through the kidneys, kidney function is a real and appropriate concern, one that grows more relevant with age. April of 2016 brought a landmark change when the FDA overhauled metformin's labeling. For decades, doctors had relied on an older blood test called serum creatinine to decide who could take the drug, and that test excluded too many people. The updated guidance switched to a more accurate measure called estimated glomerular filtration rate, or eGFR. And that single change expanded metformin eligibility to an estimated 900,000 to 2.5 million additional U.S. patients who had been kept off the drug unnecessarily. Today's guidelines break down cleanly. An eGFR of 45 or above means standard doses are fine. Between 30 and 45, the dose drops to a maximum of 1,000 milligrams per day with kidney monitoring every 3 months. Below 30, metformin needs to stop. Kidney function declines naturally with age, which means seniors cross these thresholds more often. A Scottish study found that 40% of patients with stage 4 chronic kidney disease stopped metformin within 6 months. And that makes sense given the guidelines. What nobody expected, though, came from a 2024 Scottish study that found patients who continued metformin even below the cutoff of 30 actually had lower mortality than patients who stopped. That raises questions about whether the current cutoff is too conservative, though it remains the official recommendation. The point here is that kidney-related changes to your metformin should always come from your doctor's reading of your lab results, not from a decision you make at home. Reason number 5, other factors that push people away. A handful of smaller reasons add up and contribute to the overall dropout rate. Metallic taste affects roughly 3 to 5% of people on the immediate release form, which is bothersome enough to drive some patients away. Drug interactions are also a factor, with 393 known interactions on file, 25 of them classified as major. Patients receiving medical imaging procedures involving iodinated contrast dye may also need to hold their metformin temporarily. Then there are the patients who quit because they believe lifestyle changes have made the drug unnecessary. About 7% of patients in the Weill Cornell study cited exactly that. And while achieving diabetes remission through diet and exercise is possible, the American Diabetes Association recommends keeping your A1C below 6.5% for at least 6 months, before even considering a medication-free approach with close monitoring after that. Misinformation pushes people away too. One common myth claims that metformin destroys the kidneys, which is flat out wrong since metformin does not cause kidney damage. Another says it damages the liver, also false, and some research actually suggests a benefit for people with fatty liver disease. These claims spread constantly through the internet and social media, and they convince some patients to abandon a medication that is genuinely helping them. The new controversy: does metformin blunt exercise benefits? One more reason has surfaced for questioning metformin, and this one carries real scientific weight. Several studies now show that metformin can reduce the benefits your body gets from exercise. The MASTERS trial found that lean body mass gains and thigh muscle mass gains during resistance training were blunted in adults age 65 and older who took metformin. A separate study showed metformin completely wiped out exercise-induced improvements in mitochondrial function. The most recent data came in 2025 from Dr. Stephen Malin and his team at Rutgers University. Their research showed that metformin dampened improvements in cardiovascular fitness, blood vessel function, and blood glucose reduction across both low-intensity and high-intensity exercise. Dr. Malin put it bluntly, quote, "Most healthcare providers assume 1 + 1 = 2. The problem is that most evidence shows metformin blunts exercise benefits. If you exercise and take metformin and your blood glucose does not go down, that is a problem. People taking metformin also did not gain fitness, end quote. That finding rippled through the longevity medicine community. Dr. Peter Attia, a physician and author of the book Out Live, had taken metformin for about 9 years as a potential anti-aging measure. The exercise blunting data and elevated lactate during his own training sessions led him to stop, and he has since described the longevity evidence for metformin as, quote, fuzzy, end quote. One contrasting study did not find the same exercise blunting effect, so the debate remains open. For patients with type 2 diabetes, the blood sugar benefits of metformin likely still outweigh any reduction in exercise gains. For healthy people taking it purely as an anti-aging bet, though, the calculus looks different. Metformin versus the new diabetes drugs. Part of what is amplifying the metformin conversation right now is the explosive rise of a newer drug class called GLP-1 receptor agonists, which you probably know by brand names like Ozempic and Wegovy. Between 2014 and 2022, GLP-1 receptor agonist prescriptions in the U.S. jumped from below 2.5% to 21% of all diabetes prescriptions. But here is the catch. $4 a month for metformin versus roughly $1,000 a month for Ozempic. That is 30 to 100 times more expensive. The medical community is split on what this means. Dr. Ralph DeFranzo at the University of Texas San Antonio argues that GLP-1 receptor agonists should replace metformin as first-line therapy because they target more of the underlying mechanisms driving type 2 diabetes. Dr. Silvio Inzucchi at Yale has defended metformin, noting that any drug hoping to replace it would need to be more potent, last longer, or prove superior at preventing complications, and that no other agent has definitively cleared all three of those bars. Current guidelines landed on a compromise. Metformin stays first line for most patients, but for those who already have cardiovascular disease, heart failure, or chronic kidney disease, GLP-1 receptor agonists or SGLT2 inhibitors may now come first, regardless of whether the patient also takes metformin. In practice, doctors are not swapping metformin out for GLP-1s. The newer drugs are being added alongside metformin, not instead of it, and the cost gap remains hard to ignore. One study found that switching from metformin to a GLP-1 receptor agonist added $2,453 to annual pharmacy costs. What you should know before you consider stopping. If stopping metformin has crossed your mind, a few things need to be on your radar. There is no physical withdrawal syndrome, so you will not feel sick from stopping. Your blood sugar, though, will climb once metformin's effects wear off, and that usually happens within days. Stopping also means giving up cardiovascular protection. The landmark UK prospective diabetes study showed metformin cutting heart attack risk by 39%. And all-cause mortality by 36% over more than 10 years of follow-up. Walking away from those numbers is not a casual decision. Patients who also take insulin face another wrinkle because discontinuing metformin may require a 20 to 36% increase in daily insulin dose. Research from both Hong Kong and Scotland connects stopping metformin to higher risks of major cardiovascular events, end-stage kidney disease, and death. No formal taper is needed to stop the drug, but most physicians recommend reducing the dose gradually while keeping a close eye on blood sugar. The bottom line is that no one should stop metformin without talking to their doctor first. The American Diabetes Association recommends maintaining an A1C below 6.5% for at least 6 months before considering going medication-free. After that, you need more frequent blood sugar monitoring, A1C checks every 3 months, and you should watch for symptoms like excessive thirst, frequent urination, fatigue, and blurred vision. Conclusion: let us pull all of this together. $4 a month, over 60 years of safety data, proven cardiovascular benefits, the backing of every major diabetes organization in the world. Metformin traces its origins to a medieval herbal remedy, survived decades of guilt by association with a different drug that actually deserved the bad reputation, and today it remains the most prescribed diabetes medication on Earth, and up to half of new users stop taking it within a year. The stomach problems are real, but starting at a low dose, increasing gradually, taking it with food, and switching to the extended release form eliminates the issue for most people. B12 deficiency is real, but annual testing manages it. The lactic acidosis scare is mostly a phantom, inherited from a drug that was pulled from the market nearly 50 years ago. Kidney concerns are legitimate, but they are something your doctor tracks with routine lab work. Exercise blunting is the newest and most nuanced concern, and it deserves attention, especially if you are physically active. Newer and more expensive medications are reshaping the conversation around diabetes treatment, but for most people with type 2 diabetes, metformin still forms the foundation. Dr. David Campbell from the University of Calgary framed the problem clearly, quote, "We realize that even if someone is prescribed metformin, that does not mean they are staying on metformin even for a year. The drop-off rate is really quite abrupt," end quote. What is behind that drop-off is not the drug itself. It is a failure of communication between doctors and patients about what to expect, between clinical evidence and public perception about what is actually dangerous, and between the drug's track record and persistent fears rooted in a completely different medication's history. If side effects are making metformin difficult for you, talk to your doctor before you quit. There are almost always solutions. And if you are thinking about stopping for any other reason, have that conversation first. You could be walking away from one of the most cost-effective, well-studied, and genuinely beneficial medications in modern medicine. Thank you for watching. If this video helped you, please give it a like and subscribe to the channel. And as always, this video is for educational purposes only and is not medical advice. Always talk to your healthcare provider before making any changes to your medication.